afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from AfricaCDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The main speaker for the session is Dr. Jean Kaseya, the Director General of AfricaCDC, who will provide a special briefing and situation analysis on the Mpox situation across DRC and other member states. Over to you, DG.
Good morning, good afternoon, good evening, all of you. I hope you can hear me. We start this press conference by saying thank you to all of you for the support you are providing to the Mpox response in Africa. We are taking this press conference today from New York, where we are attending the UN General Assembly. I wanted to give you an overview of what we did and where we are today. And I will ask my colleagues to start with the presentation. Yes, please, let us go ahead. Next slide, please. Okay, now we are familiar with the presentation we are making in terms of epidemiological situation in Africa. And as you can see, we have 32,407 cases. And you will see in the next slide new cases in Africa. But I wanted to draw your attention for the number of deaths that we have currently. Last week, we were talking about 738 deaths, but you can see here we are talking about 840 deaths. As you can see, Central African region is still reporting more cases than other regions. Last week, for the same period of time in 2023, we said there was an increase of 177%. And this is also what we presented to the meeting of head of state on Sunday. But on the week 37, if we compare 2023 to 2024, you see the increase of 194%. It's just to show to all of us that we still have increase in terms of cases in Africa. Next slide. When we talk about it, we talk mostly about the new cases. You will see that from the 3-4 past weeks, we start to have an average of 2,000 to 2,500 new cases per week. And you will see here we have 2,910 new cases notified. As we reported, it's mostly in Central Africa region and Eastern Africa that we have more cases. And but we know also other regions are reporting cases. We wanted to give more information about deaths because we are talking about 16 new deaths, just because last week we didn't record in the system 86 deaths due to Mpox. And when the different authorities, they recorded these deaths, this is why we have a total of 102 by considering the 86 deaths that were included in the reporting of African countries. Next slide. What is the main information you can get here? Because we want to see if our lab system is performant. we are talking about the testing rate. Let me remind you that in Western countries and in Asia, the testing rate is 100%. But you'll see the average in Africa is 49.5%. And mostly driven by DRC, where the testing rate is 38.6%. It means what we are providing as information in terms of confirmed cases is not really reflecting the reality, because we are not testing as we must do. But we can also discuss the positivity rate. That is around 40%. And you'll see in red, all countries having the positivity rate less than 20%. That one is a major indication on either the way we are collecting sample, the way we are transporting sample, the way we are getting the samples in a lab, and how we are analyzing that. There are a number of factors that can explain the low positivity rate. And lab remains for us a key priority, as we'll discuss that in one of the slides. Next slide, please. We are clearly saying that there is increase of cases across all affected regions in Africa. And there are countries reporting suspected cases, but because they cannot test, we cannot put them as confirmed case or as country with outbreak. I think if we have to include all countries with suspected cases, even when the test is negative, we'll have more than 15 countries we are talking about. What we are not also doing well is, in addition to the lab and surveillance, we are not doing well on the contact tracing. We want to trace at least 90% of contact, but we have only around 4% of contact tracing. That is also a major indication on the way our surveillance system is performing. We are also discussing about the 68% of cases with unknown epidemiological link. This is a major concern. I think for all of you who attended the meeting that we had on Sunday with Head of State, even Dr. Tedros said there are so many unknowns about Mpox. And that is leading for so many studies we need to conduct to understand the Mpox and how we can stop this outbreak. We already highlighted to you that surveillance, contact tracing, and lab network now constitute what we call our immediate priority. And we will give you some information on how we are providing support to countries to improve in this area. Data quality is also a major issue. I think we discussed the issue of 86 deaths that were incorporated this week in the system while it happened last week. But this is just deaths. If we have to go deeply on all cases that we have, I think we can agree that number of cases that we are providing to you, it's just the peak of iceberg, because no one can say this is the reality that we are experiencing in Africa. And this is why we are also working on the case definition, and we have a number of webinars ongoing to support that, in addition to the community-based surveillance. Next slide. What is the response at strategic level from last week and this week? It means from Friday last week to today, Thursday. The main activity that we organized, and all of you were informed about it, it was the meeting of Committee of Head of State and Government of AfricaCDC, well attended from the continent, also from partners. And this meeting was led by His Excellency Mohamed Ghazouani, President of Mauritania, who was also leading AU. What are key results that came from this meeting? First, our head of state and partners, they congratulated AfricaCDC on the way we are leading the Mpox response. And they also reaffirmed their total support to the continental Mpox preparedness and response plan that was developed by all partners under the co-leadership of AfricaCDC and WHO. As one of the results of the strategic move that we took in Africa, we have this incident management team where all partners are sitting. We are talking about 26 partners sitting in this team and providing support to affected countries. I want also to inform you that Head of State decided to create the Mpox Fund that can receive all contributions from member states and partners. And we saw already countries pledging funds to this Mpox Fund. And we saw also some partners pledging funds. In total, we got around 314 million out of the 599 we have in our continental response plan. I wanted to say that 129 million came from pandemic fund, and I think you saw the statement that came from AfricaCDC to support this one that came from pandemic fund. Our team is working with the pandemic fund team on the way to allocate these resources in the 10 countries that were approved for support. In addition to the $314 million, we also secured 4.3 million doses of vaccines. We want to remind that AfricaCDC is talking about 10+ million doses to stop this outbreak and start to control this disease. But what was not in our plan, but it was shared with us by Sept, is around 72 million for vaccine development, Mpox vaccine development by BioNTech, and 145 million to support the expansion of the manufacturing capacity in Africa, especially in Rwanda. We also got an announcement during that meeting that the US will make on Tuesday a huge announcement on the way they are supporting the response. And it came out on Tuesday, this $500 million that the US is providing to support the continental response plan. It was written in the fact sheet from the White House. And also 1 million doses, starting with 300,000 doses. And if countries are using that, then we are moving crescendo. Yes, you can tell me, DG, you got everything you wanted. You wanted 599 million, but today you have around $814 million. Yes, it's true. Even more than that, around 1 billion if we consider this huge support from Sept, and if we consider also additional support. But let us be clear on that. This plan is flexible. The outbreak is growing. when we were developing this plan, some countries were not affected. And we still have high-risk countries where we need to focus and to build capacity. It means we'll redistribute this funding based on the discussions that we have with all partners to ensure that all affected countries and high-risk countries are getting appropriate support against Mpox. We agree with Head of State to have a follow-up meeting in November just to update them on the fundraising and also on the improvement we are making in the field. As we are seeing every day, our objective is to stop this outbreak in the next 6 months. And we need full support from our member state and from our partners. Next slide. We talked about strategic level. Let us talk about technical level. This week, we are sending to some countries vaccines this week and next week in Rwanda, in South Africa, Burundi, Cameroon, some vaccines that we already have with European Union, but also supporting some countries additional doses that we can get. We congratulate again Rwanda for starting the campaign. We are expecting DRC to start beginning of October, and we are also supporting other countries to follow what the two countries are planning. Currently, we have a technical review committee that will meet on Monday. Dr. Ngashi will talk more about it. This team of experts coming from different organizations will assess the quality of the vaccination plan and to advise countries on the best way to move forward with their campaign. Research is a major component, and you will see that we have a number of studies ongoing. We have a number of documents that we are releasing, like this coordinated research roadmap, jointly developed by AfricaCDC, WHO, Sept, and NIH. And we have also in some initiatives that we are taking in the area of diagnostics. You know, in August, there was the meeting of the AfricaCDC Diagnostic Advisory Committee, and the recommendations are out on what we have as available diagnostics. The lab team will come back to that. Because surveillance is weak, we are bringing a strong component on community-based surveillance, and we are bringing our community focus to support the response. I think we are just giving you some highlights on how we are managing the response at technical level, but we can still discuss that with your questions. Next slide. Next slide to say thank you to all of you. And this airplane is embarking all of us on the way to fight Mpox and to stop this outbreak. We thank you and we welcome your questions. Back to you, Margaret.
Thank you, DG. Let's take the first two questions from Emery of BBC, based in Kinshasa. The first question asks, Dr. Kaseya, can you bring us to speed on the vaccine deployment in DRC? For example, what will be the provinces with priority to roll out the vaccine schedule for 2nd of October? That's the first question. The second question says about the recent clade 1B. Has this MVA-BN vaccine from Bavaria Nordic been subject to a clinical trial before the rollout in the DRC? You can take those two, DG.
Yes, I will respond to the second one. Dr. Ngashi and Professor Nikes, they will support on the first one because the IMST is responsible for the response and they are working with the country, but they will also complement. No, the rollout of vaccine, the Bavarian vaccine, is not subject to clinical trial because this vaccine, as we are saying every day, was used in the US, in Europe, and it was tested. And today, as you know, this vaccine got the WHO pre-qualification. It means we can be assured about the safety of the vaccine, and we don't need to go through clinical trial for 1B, for Bavarian vaccine. Let me hand over to my colleagues, Dr. Ngashi.
Yes, thank you very much, DG. Regarding the priority provinces, DRC has identified 11 zones de santé for Block 1, and then 19 zones de santé for Block 2, those covering 3 provinces, that is Sud Kivu, Equateur, Chuapa. And then also there is consideration for Kinshasa, given the fact that recently they've observed a rapid increase of cases in Kinshasa. And then discussions are now to also include Kinshasa as one of the areas that to be prioritized.
Back to you, Margaret.
Yeah, thank you very much, DG and Dr. Ngashi. I'll now pass it on to the floor. Let's take the questions from NPR. Gabrielle, you have the floor.
Thank you very much. I had a quick question. This morning, the WHO had a webinar about Mpox, and they mentioned the sexual transmission rate at a very high 96% of cases. And I just wanted to understand how that overlays with the number of children who are getting infected. Are some of those sexual transmissions, or does that not seem to be happening among the pediatric population? Thank you.
Thank you very much. Let's take the next one. Carmen, you have the floor.
Thank you so much, Margaret. I had 2 questions. The first one is actually on Kinshasa. How worried are you about the suspected cases there and that it might, spread quite fast given, how big the city is? And the second one is on the 500 million from the US. I was wondering if you got any clarity about, are this fully new money? Do they include money that they've sort of like already committed or spent as part of the response so far in the DRC and neighboring countries? I was just trying to understand exactly, more details about this pot of money from the US. Thank you.
Thank you. Over to you, DG.
Thank you. I don't know if Professor Nikes is connected with Dr. Mosoka for the first question. Professor Nikes, are you connected?
Yes.
Is it about Kinshasa?
Sexual transmission. Okay. If it's not connected, Dr. Ngashi, we can.
Yes, I think there are 4 patterns of transmission of Mpox in the DRC. You have on the western part of it where we have 1A, it is physical and community transmission, household transmission. On the eastern part where we have 1B, that's where we have the sexual transmission. But when you unpack again data from Sud Kivu, you'll see that toward the south, where you have networks of key populations, sex workers, that's what we see the sexual transmission rate is predominant. But in the same province, you also have areas where you still have the traditional community transmission that is going on in the adult population. And then there are other areas where you have a combination of the transmission in children and transmission in adults. I think that's what the DG was explaining before, that there is that complexity, of the combination of different transmission modes in the same province of Sud Kivu that require a better understanding of what is going on. Just to clarify that sexual transmission is not observed everywhere. I think there are provinces that are more metropolitan with networks of sex workers. That's why you see the sexual transmission. And in other areas that are more rural, it is the traditional community transmission that is going on. Yeah.
Thank you. Carmen, we didn't get very well your question on the vaccine because my colleague Chanel will respond on that. Can you please help us to repeat that question, then she can get it.
Carmen, are you with us? Yeah.
Yes, I am. So is it the question about Kinshasa? I was wondering how worried you are. I mean, as far as I saw, there were a few hundred suspected cases reported in the city. And I was wondering if that worries you in any way that, it could widen the outbreak very fast, given how big the city is. Thank you.
Okay.
Yeah. Yes, I think that is something that worries us very much, to be honest. One of the reasons why we have now discussed with the Minister of Health of DRC to adjust the vaccination plan a little bit to also include Kinshasa now. As you know, Kinshasa is a city of about 15 million people still are waiting for the census. The crowding is real. I think for those that know the city, you know that the crowding in terms of accommodation, the crowding in transportation, the crowding in the market, that makes it very prone for rapid expansion. In addition to that is also the opening of Kinshasa to the other countries and to the world. I think for those reasons, I think Kinshasa has become a priority now for not only vaccination, but the intensification of the entire response in terms of surveillance, in terms of diagnostics, in terms of infection prevention and control, and also targeting the schools to ensure that the basic, IPC and surveillance hand washing facilities are there, because of the mass of people really makes Kinshasa much more vulnerable for the rapid expansion of the disease.
Thank you. Back to you, Margaret.
Thank you, DG. Thank you, Dr. Ngashi. Let's move on to the next question from Sarah Jerving of DVEX. Sarah, you have the floor. Sarah, can you hear us?
Can you hear me now? Okay,
yes,
great. Thank you so much. You mentioned that 68% of cases have no epidemiological link. Can you provide more information on that and why that's the case? Thank you.
Thank you, Sarah. Let's get the next questions. Lionel Lidigu from the Nation Media Group, you have the floor.
Thank you so much. My question to Dr. Kaseya is just a follow-up on the epidemiologists AfricaCDC said a few weeks ago it will dispatch to countries. I would love to know how many, for example, have been dispatched to Kenya, and what have they observed in terms of how we are doing the testing and the quality, the kind of quality incident management we should expect moving forward. Thank you.
Thank you. Over to you, DG.
Regarding the testing, my colleague, Dr. Yenyu, who is the director for lab, will respond. Regarding the unknown epidemiological link, my colleague from IMST will respond. Yes.
Thank you very much, DG. 68% of cases have no link. What does that mean? Because usually when there are positive cases, then you take the contact of those positive cases and start following them. When cases come in those groups, you know that they're linked to the index case that was identified. That is a good sign that at least the cases are happening in the group of people that you control the transmission. But when you have the majority of cases coming outside the list of contacts, it means that there are chains of transmissions that you don't control. That shows that your surveillance is not working, which is the reality in most of these countries, for two reasons. The vast majority of the cases that are being identified, it is because they fall sick and they come on their own. That means it is passive surveillance. It shouldn't be like that. I say there should be active cases that identify those people and get them out of the system. And the second thing, even those that have been identified and confirmed as positive, as the DG presented, is less than 3% of the contacts that are being followed. That means that the vast majority of them, we don't know the contact and we can't trace them. That again confirms that we need more investment in surveillance to make sure that the vast majority of cases are coming among those that are listed as contact, to give us assurance that we are now getting close to controlling really the chain of transmission. That is important for us to break that and control the outbreak.
Yeah, Dr. Yenyo.
Yeah, I think in terms of testing, specific to Kenya was a question. Kenya has a very strong capacity for testing and sequencing, and we have been working with them, supporting, and we are even Kenyan colleagues participating in our training program. So Kenya has very few suspected cases, so the testing rate in Kenya is almost 100%, and they are also ready, to expand the testing capacity if more is needed, and to support that one. So we are working, distributing diagnostics and bringing additional sequencing reagents and so on. So and generally, there is no really a big challenge in terms of testing in Kenya because of their strong PCR testing method. Thank you.
Thank you. Let me come back. I see Carmen. Sorry, Carmen, we missed that, the $500 million. We have meeting today, Dr. Tedros, myself and our teams, with the US team led by Xavier Becerra, the Minister of Health, US, I think in the next 3 hours, to discuss on how everything will be dispatched, how we can use this $500 million. We cannot say if this is, as you are asking, if this is new money or this is, money they are repurposing. But I think after this meeting, we'll have more information. What is important for us, there is a commitment of $500 million coming from the US to support African countries, to support the coordinated response plan. To complement also the response that Dr. Ngashi gave from Sarah, the 68% of unknown epidemiological link. I think all of us, we saw that case from India that was reported, I think 2 days ago, of this young person, 38-year-old man who was in the United Arab Emirates. And what this information is giving us as lesson. First, when I discussed with Indian authorities, they didn't tell me that that person from India was in contact with Africans. It means if this is the case, somehow we missed something. And when we are talking about contact tracing, this is also the information we are looking for, because that one must alert even authorities of United Arab Emirates. We can assume that clade 1b is circulating in this country. And we have so many unknowns. I think till the day we'll start to say that we have accurate information on the contact tracing, we have accurate information on all clades that are circulating, we can link everything, then I can say from African side, we can say we can move toward end of this outbreak. But from the world side, it will be the WHO to say that. Over to you, Margaret.
Thank you, DG. Let's take the next question from Motesem from SciDevNet. You have the floor.
Director Margaret, I think there was a question on the deployment of epidemiologists, I think. What you can say that we have 44 that have already been deployed. 19 in the process of deployment and another 12 in the process of recruitment. I think that's about 75 that are being considered right now.
Thank you, Dr. Ngashi. Motosem, you have the floor.
Yes. Okay. Thank you so much. I think you can hear me now.
Yes.
Mainly my question about the North African RCC and the response to Mpox. I mean, 1 month ago, there was the launching of the Regional Technical Committee of the North African RCC. I think the last one to be launched. So my question is this committee and North African RCC ready to coordinate a response if the situation of Mpox worsen in North Africa? And generally, what is taking place now in Morocco and its neighboring countries in preparedness for Mpox? Thank you.
Thank you. Let's take those two, DG. Over to you.
Yes, I will respond on the North RCC and the response in North Africa. You saw that I was in Morocco the day after the declaration of this case, because it was the first time in 2024 to have confirmed case in North Africa. And we take it seriously, knowing that Morocco is also a hub for many African countries, but also other continents. But we are not afraid about the capacity of Morocco to contain this outbreak. Even we are not afraid about the capacity of many other countries in North Africa to contain that. I was in discussion with a number of ministers in North Africa, including Egypt, Algeria. And I think we are well positioned to, they are well positioned to respond to any outbreak. Yes, our RCC is there to support all countries, and this is what we are doing. Currently, North RCC already activated the Emergency Operations Center. We are following what's happening in all of these countries, and we are supporting on the cross-border surveillance and approach. I think we are fortunate to have even the person who's leading this Northern RCC, Dr. Wessam, who was leading the Emergency Operations Center in AfricaCDC, who knows how to manage all of these issues. I don't know, is there any complement?
Yes, DJ, just to say that what the coordinator of the Northern RCC is doing now is right now in Kinshasa, also sitting with the Continental Incident Management Support Team, just to link up the strategies that are being deployed on the continent also with the North. I think just to say that it's an activity, the EOC is already functioning and linked with the Continental Response Team.
Thank you very much, Dr. Ngashi. Let's move on to the next question from Christopher from Deutschland, Germany. The first question is, who are the population groups to receive Mpox vaccines first, considering that only a limited number of doses have arrived? The second question is, can you explain the difference in test positivity rates in countries such as Burundi, which has 38.4% and Rwanda 0.3%? The third question is, since immunosuppression is a risk factor for severe Mpox infection, how worried are you that the Mpox outbreak will reach regions with a higher number of people who are living with HIV and who are not receiving antiretroviral treatments? Let's take those three. Over to you, DG.
Thank you. Let me hand over to our colleagues from IMST to respond to these three questions.
Yes, thank you very much, DG. On the first question regarding the priority populations being considered given the scarcity of vaccines, now the priority is given for post-exposure prophylaxis to the contacts of the index cases that have been confirmed. That's the first group. But at the same time, there's also the pre-exposure prophylaxis prioritizing the healthcare workers because of the high exposure. the key populations, meaning commercial sex workers and men having sex with men. And in addition to that, there's also a focus on the children. I think in those areas where the children are affected. And finally is, I think the other group is the crowding, where you have people in refugee camps, internally displaced population, and the prisons. Now, I think that's in general. But for regions like on the east, where you have cases that have been identified among truck drivers and also traders, cross-border traders like in Rwanda, I think those have also been included. And finally is the group of those that are immunocompromised, HIV positive in particular. Now, the question about the worry about the transmission in people that are immunocompromised, we have already a case of South Africa. If you look at the cases in South Africa, all the cases were among those that were HIV positive. And the DG was just talking about the situation in Rwanda, where we've also seen again Mpox in the population, those that are HIV. That's the reason why those that are immunocompromised, HIV in particular, have also been prioritized as a group for vaccination. And all those countries like South Africa are being supported now to put up measures really to protect those populations, given that the transmission is the sexual transmission, more really leveraging the resources that are there with the HIV programs, to also protect those populations. And finally, is the question on the positivity rate. Positivity rate is a result of two things. Positivity rate that is low means that they are bringing more samples of people that respond to the case definition, but when they are tested in the laboratory, they turn out to be negative. Now, when they turn out to be negative, what does that mean? The first thing is the quality of the specimen itself. Now, remember that most of the people that collect these specimens have not been trained, to understand what is quality specimen that need to be collected for Mpox. That is one. And the second is the transportation system, to get the samples from the areas where they're taken to the laboratory where it has to be tested. I think quality of the sample is one element, but there's one other very important element, is the fact that there are other diseases that respond to the case definition which are not Mpox. In the DRC, for example, the ENRL, which is the bigger research laboratory, has re-examined the positive to understand what are the other diseases that these people might be suffering from. They have identified that in small children, measles, there are many cases of measles. They have also identified chickenpox and herpes among the other population. Just to say that that's really a reflection of the weakness of the surveillance system. Now, with the additional effort that Mpox is bringing, we are able to also pick up some of the cases that were missed, through the weak surveillance system that we see. That's the reason why there's low positivity rate, it is really an opportunity to go and investigate and understand what is it that we could have been missing on the surveillance side that we can then address, taking the opportunity of the Mpox.
Thank you, Dr. Ngashi. Let's take another one from the floor. This one is from Carmen. I think she had a question that was not answered. The question was about the 500 million from the US. Does DG have clarity on whether this includes money already spent or committed by the US? Over to you, DG.
I already responded to that. I said we have a meeting today with the Secretary of Health. It means the Minister of Health, US, and the US team that will comprise, I think, around 10 people from various agencies, and AfricaCDC team and WHO team to sit to discuss about this $500 million and also the 1 million doses. I think that one will update colleagues next time.
Thank you, DG. I see Sarah from Javing has a hand up as well. Sarah, you can have the floor.
Thank you so much. You talked about the unknowns with this outbreak. Would you mind listing just the top key unknowns?
Thank you, Sarah. Over to you, DG.
Dr. Ngachi, did you get what Sarah said?
Yeah, I think she's asking about the unknowns. I think what the DG was saying that there is a lot that we do not know when it comes to Mpox. One is that we do not have a full understanding of the epidemiology of Mpox and the transmission dynamics. I think that is something that we are also trying to understand. I think what are some of the factors that, for example, explain the high numbers of children that are being infected that we do not understand. I think that those are some of the unknowns. And there's something else also on the social anthropological side of it. We also need to understand what are the perceptions of these communities vis-a-vis Mpox transmission and the behaviors that can also facilitate the transmission in those areas. Number three, when it comes to the medical countermeasures, there's a lot that we don't know. For example, now, we counted on tecovirimat as the treatment for Mpox. Now, the study in the DRC has shown that really the effectiveness that was demonstrated with clade B has not been proven for clade 1. Now, what else do we have as treatment for Mpox? We also do not know how would the MVA vaccine that we are using also behave in children that are below 12 years. I think we also need to understand in terms of safety, in terms of immunogenicity, in terms of effectiveness of those of that very popular vaccine not in children. Those are the things that the DG was saying that for all that, we've also built in a very strong research agenda to find also answers to some of those questions to be able to help us improve on the interventions that we are providing during the Mpox outbreak.
Let me be clear on that. I think we are talking with our partners, with our colleagues from Western countries, and we are telling them they are also responsible of the situation that's happening in Africa. When we had the public health emergency of international concern in 2022, they focused just on clade 2 that was in Europe and the US. They knew that there was a clade 1 in Africa. They didn't conduct studies, they didn't conduct researches for the clade 1. And when we're lifting the status of public health emergency of international concern, they didn't see that the clade 1 that we had in Africa already mutated to the clade 1b. We are not talking about a new variant. We are talking about clade 1 that was there for a very long time, but no one wanted to focus on that. Because if at that time, studies were conducted using tecovirimat, studies were conducted today, we don't have antigen test for clade 1. This is why even our community-based surveillance is a major issue. People are just using the case definition to bring a number of people who can have symptoms. Today, to conduct the cross-border surveillance is a major issue because we don't have this rapid test. We are talking about gene experts. Today, we don't have a test that can tell us this is clade 1. We are just excluding clade 2 to consider that we have clade 1. You see, that one, it must be clearly said. It's also the responsibility of our colleagues and partners. And this is why today we are calling for solidarity. We are calling for putting our efforts together, not blaming someone, but saying, we made mistakes, let us correct that, let us work together. I think this is the spirit that we have. We are not only also blaming them, but we are telling them the truth in terms of this all unknowns that we have. 80% of unknowns are mostly due because our colleagues and partners, they didn't want to see the reality that was going on. Otherwise, today we'll not talk about all of these unknowns. Back to you, Margaret.
Thank you, DG. Let's take another one from the chat room. Someone called Gumbo says, can you talk about the DRC's neighboring countries like Tanzania and Uganda? What is going on regarding the Mpox response measures? Let's take another one from David. No, this is Stephen asking about the community-based surveillance. What plans do you have to make it watertight? It's obvious there's little or no surveillance in these countries. What are the measures being taken? Over to you, DG.
Thank you so much. I like to give to IMST all questions related to the response at country level, but quickly, regarding Uganda, I think you saw that we have around 212 suspected cases, and almost all of them were tested. This is why we are talking about 100% of testing rate. And the positivity rate was 10%. I think Dr. Ngashi already explained all issues related to the positivity rate. But also, as we say, these 212 cases are just the peak of iceberg. No one can say, knowing the cross-border, mostly with the truck drivers movement, knowing the weakness of our surveillance system, no one can say that these 212 suspected cases, it's accurate. Regarding Tanzania, officially, I say officially, Tanzania didn't declare cases. Is it the reality or not? Knowing that Tanzania is the neighbor of Burundi, Uganda, Kenya, I think it's in the Eastern African community. And we can also challenge, I think, if the surveillance system is really working. But officially, today, we don't have cases in Tanzania. Dr. Ngashi, about the community-based surveillance.
Yeah, thank you very much, DG. I think one of the things that we've also observed is that the community-based surveillance is weak because the community health workers and community health programs have not been fully involved into the Mpox response. I think that is what we are now working with countries to take advantage of all the ongoing effort to increase the number of community health workers, and then to ensure that those community health workers are not only there for routine programs, but they also have a role to play in emergency preparedness and response, in particular in the area of surveillance. With the active case funding, we're already seeing that in Central Africa, that has already started in Bangui. The results that I've gotten in Central Africa, it's because of that exactly. We are also working with the DRC, with the minister, to roll out the 40,000 community health workers to be able to have that contribution. Now, as the DG said, for the neighboring countries to the DRC are in two categories. There are those that are in risk category number 1. All of them do have plans that are already in place, and they have also been included in the support they're getting in terms of strengthening surveillance, strengthening laboratory system, and also including vaccination, like Uganda, Rwanda, they are all included. I think for those like Tanzania that the teacher said, where there's no case, they are part of the category 2, which are the countries that are at high risk because of the proximity with those that are already infected. All those countries, if you look at the continental plan, they are included there. There is funding for them, and the support has already started to help them put in place their preparedness plan on one side, and start also strengthen some of the activities, in particular surveillance at the point of entry, to make sure that they have the capacity to identify their cases, and also set up the strong capacity laboratory so that if they identify cases, then they can test them. I think that's really work that is ongoing, because we consider that category 2 a country that might come very soon. As you've seen, Morocco was one of the category 2 countries. It didn't take long now. We have a case in Morocco. Over to you.
Thank you very much, Dr. Ngashi. And with that, we've come to the end of the press briefing today. I will now hand it over to the DG for his closing remarks. Over to you, DG.
Many thanks, colleagues. I know most of you, maybe all of you can have additional questions. Please don't hesitate. If you have questions, to email us. We are putting in place a team to respond to all questions because it's critical for you to get answers on your questions. Wanted to say, let us celebrate together the success of the AfricaCDC and WHO approach by bringing all partners together, by bringing all member states together. Today, what we managed to put in place, we already raised $1 billion. We believe we can raise more than that to better support our countries. We are saying we don't just have 15 countries. We have 15 plus other 15 others that are at risk. And any of them can today be affected. This is why our effort is not just on the 15 countries. Yes, there it's our priority, number one, but also to other countries where we need to strengthen the surveillance to ensure that if there is any case, it can be reported timely and action can be taken. We are strengthening the lab system to ensure that all countries have capacity to test and to report on that. And we are also strengthening capacity in terms of vaccination, and our colleagues are working so hard with other partners to ensure that all countries, they have the vaccination plan in place, and we know also their needs, and we are working for manufacturers, we are working with other partners to ensure that we are getting appropriate doses of vaccine. We are having also a number of studies ongoing. I think we'll start to update you on that. The last one is about accountability and transparency. Now that we already inform all partners and all member states, we are putting in place a dashboard. This dashboard will help even you journalists and all of our community members, all of our leaders, to go to check, to click, to know what is the situation in each country, in each region, and at continental level, to click and to know how much each country is providing for response. As I'm telling you, we are glad to see at least 10% of the response is coming from the continent, because a country like DRC is providing $10 million, a country like Burundi is providing 1 million out of the 8 they want, and so and so and so. I was even informed a country like Cote d'Ivoire, they are providing $2 million. You see, we want each country, based on the dashboard, to know exactly what is the response they are providing. We want also partners to be accountable. We don't want to see a partner coming talking about big amount of money. We want to know where this money is going, what this money is doing. And that one is what we call the mutual accountability. And we are also having a window on logistics and vaccines. I think this dashboard that will be launched, that I am sure my colleagues are working so hard for that. Next week on Thursday, I will start by sharing with you the link of the dashboard. My presentation will be based on the dashboard. And this dashboard will help you now and will help our partners. Those who contributed would not be there. They will ask, they will share information, because we want to know how much we provided for Mpox. What will be the legacy from Mpox to the future of Africa? Our conclusion will be, before Mpox will not be the same after Mpox. We need to have a strong surveillance and lab system in place. We need to have local manufacturing moving. Thank you so much. Let us meet again next Thursday.